BJGMC to brief about the award.
Hello everyone. A very warm good morning to all of you. A very pleasant weather today. No rains. I hope this situation will remain today and also tomorrow. Now we will start the first session of the conference, that is the Dr. P.M. Khare Award. This award was started in the 4th Maharashtra chapter conference of IMM in 1998 in the memory of Dr. P.M. Khare, Professor and Head, Department of Microbiology, BJGMC, Pune. The award is for best oral paper. It is for the young microbiologist whose experience in microbiology should not be more than 5 years and age must be less than 35 years of age. There are total 9 minutes for the paper, 7 minutes for the presentation and 2 minutes for the question and answer. First bell will ring at the end of 5 minutes and the second bell will ring at the end of 7 minutes. If the candidate go beyond that, then there will be no question answers for that paper. The candidate is asked to submit full paper for the Dr. P.M. Khare Award without revealing any identity of the institution. And judges will select only 3 papers for the presentation. Now I request our opening batsman, Dr. Anu and Dr. Shilpa, to start the session. Over to you for the session.
Hand over the mic to the chairperson and they can start with the first presentation by asking the presenter to come on the dais to present the PM Khare Award paper.
Good morning all respected seniors and the gathering over here. Now we will be starting with PM Khare paper. So I will just give some instructions regarding that. Now everybody, all the presenters will be having total 7 minutes for presentation and 2 minutes for discussion. Now after 5 minutes the first bell will ring and next bell will be ringing after 2 minutes. Now after total 7 minutes, if they extend, there won't be any discussion. Otherwise, after 7 minutes, there will be 2 minutes of discussion. So sir will tell the candidates' names and they will be coming and presenting their paper. Thank you.
Thank you, madam. So we are also really excited to hear from the budding scientists as you are. So without wasting time, I would like to first invite Dr. Rashmita Das, who will be talking about S gene target failure and SARS-CoV-2. Dr. Rashmita, please.
His presentation is S gene target failure and SARS-CoV-2. Over the past 2 years, the SARS-CoV-2 virus has evolved to give rise to new variants with improved transmissibility and immune escape properties. Few notable variants of concern that have emerged in the past are alpha, beta, gamma, delta, and the most recent, the Omicron variant. It is a highly divergent variant with at least 26 to 32 mutations in its receptor binding domain of the spike protein. The presence of such high mutations raised concerns for its early detection. In the meanwhile, TACPath COVID-19 combo kit by Thermo Fisher Scientific, targeting the gene spike gene, nucleocapsid gene, and ORF gene, showed reduced S gene target sensitivity due to presence of deletion at H16 and V70. This phenomena was known as S gene target failure. And on 28 November 2021, WHO advised the countries globally for enhanced surveillance for Omicron variant using the SGTF approach and prioritizing these samples for genome sequencing. Therefore, in line with WHO guidelines for using SGTF approach, the present study was carried out to assess the utility of SGTF approach in the early detection of Omicron variant, considering WGS as the gold standard. The objectives of the study: to study the distribution of SGTF and non-SGTF over the study period, to study the correlation between SARS-CoV-2 variants and SGTF results, and to study the performance characteristics of SGTF approach in detection of Omicron variant, considering WGS as the gold standard test. A total of 520 RT-PCR positive RNA samples with a cycle threshold value of 25 were included in the study. The samples were collected from all collection centers in Pune between 1st December 2021 to 22nd December 2022. A multiplex real-time RT-PCR assay using TaqPath COVID-19 combo kit was done on Quant Studio 6 Pro real-time PCR system. SGTF was defined as failure to detect the S gene target in samples testing positive for N gene and ORF1 gene targets. Irrespective of S gene amplification results, SARS-CoV-2 whole genome sequencing of 520 RNA samples was performed using the GridION sequencer from Oxford Nanotechnology. Lineage and clade analysis was done using the Pangolin and Nextclade software. Now coming to results, out of the 520 samples processed, 33.85% were from the month of December 2021, 55.77% from January 2022, and 10.38% from the month of February 2022. The mean age of the study population was 33.8 years. There were 59.23% were males and 40.77% were females. Of 520 samples tested for SGTF, 31.35% showed S gene target failure and 68.35% were non-SGTF samples. As we can see here, the presence of SGTF samples started to gradually rise from the first week of December and declined towards the end of January 2022. Now looking at the distribution of SARS-CoV-2 variant over the study period, December 2021 was dominated by Delta sublineages, whereas in the months of January and February 2022, Omicron subvariant BA.2 was predominant, followed by BA.1. As we can see, Delta variant was almost completely replaced by Omicron variant by first week of January. Both Table 1 and Figure 3 show the correlation between SARS-CoV-2 variants and the SGTF results. Among the Omicron variants, SGTF was seen in 88.89% of BA.1 and BA.1.1 each, and only 3.54% of BA.2 cases showed S gene target failure. Next, looking at the performance characteristics of SGTF approach, the SGTF had a good performance for detection of both BA.1 and BA.1.1, whereas had a poor sensitivity for detection of BA.2 variant. Now coming to discussion, since its first designation as a VOC, the virus has mutated further to emerge into several sublineages of of which BA.2 and its sublineages are the dominant variants globally. In the present day of the sequences deposited on GZ, Omicron accounts for 99% of all the sequences. As we can see, looking at the world data for the presence of H69 and V70 deletion mutation, among all the Omicron subvariants, 96 to 97% of this gene is present in BA.1, 1.1, and BA.3. However, it is typically absent in BA.2. Other variants showing the presence of this deletion are alpha variant C.36.3.1. Omicron and its subvariants have markedly reduced in vitro susceptibility to various anti-SARS-CoV-2 monoclonal antibodies. Therefore, their use in Omicron cases is limited by US FDA. Therefore, the correct characterization of SARS-CoV-2 variant by WGS is essential, not only to understand the transmission dynamics of outbreaks, but also to guide patient management. To conclude, the SGTF approach lost its significance in the later part of the study period, as the later half was dominated by BA.2 Omicron sublineage, which escapes detection by SGTF approach. Samples positive for SGTF must be confirmed by sequencing to characterize the variant and rule out the variants circulating at low frequencies in a given population at a given point in time. With the rapid spread of BA.2 to various parts of the world, the sequencing of positive samples, irrespective of their S gene status, will help us to closely monitor the SARS-CoV-2 virus. Timely modifications of various testing protocols is essential for appropriate epidemiological and preventive measures. These are my references. Thank you.
So, thank you, Dr. Rashmita, for the excellent presentation. So, before I open up the floor for uh, discussion, I would like to ask one question. So, are there any public health implications of this work?
Certainly, sir, as I mentioned, there are monoclonal antibodies as a treatment. Omicron does not respond to such treatments. So in that case, if BA.2, as we are missing BA.2, as we are only sequencing as S-gene target failure samples and not non-SGTF, if we prioritize those samples, then we are missing on BA.2s at that point in time. So if we miss on BA.2, we are not identifying it. As a result, it has got, as we know, monoclonal antibodies are not here. So treatment cannot be appropriate, will not be.
Okay, thank you. So now we open up the floor for questions. So due to
samples for sequencing, but those which are not showing SGTF, maximum were BA.2. So we are missing on those cases. So it would be like, there are studies where they have characterized on the basis of SGTF, Omicron and non-Omicron cases. So that would be wrong on that part. So we cannot characterize them as non-Omicron cases.
So I call upon Rashmita to collect her certificate. Sir will be honoring her with the.
Now we would like to invite Dr. Shalini on comparative evaluation of colistin susceptibility testing methods and the resistance pattern of colistin among carbapenem resistant K pneumonia isolates in a tertiary care setup. Dr. Shalini, please.
Hello. A very good morning to one and all. So the title for my today's presentation is Comparative Evaluation of Colistin Susceptibility Testing Methods and the Resistant Pattern of Colistin among Carbapenem-resistant Klebsiella pneumoniae isolates in a tertiary care setup. Heading towards the introduction. So as we know, the most common agents associated with nosocomial infections are the escape pathogens. Klebsiella pneumoniae is one of them. So according to the WHO Global Report on Surveillance of AMR, Klebsiella pneumoniae was considered one of the top 3 species causing UTI, meningitis, SSI, and sepsis. Among them, carbapenem-resistant Klebsiella pneumoniae remains a significant challenge associated with morbidity and mortality worldwide. So to cope up with this, colistin, being a 50-year-old antibiotic, becomes the last resort therapeutic option to deal with such infections. So let's see what is colistin. So isolated from Panibacillus polymixa, subspecies colistinus, colistin, also known as polymyxin E, is a circular polycationic antimicrobial agent with its hydrophilic and lipophilic properties. So for clinical use, 2 forms of colistin are available. One is CMS for parenteral use and colistin sulfate for inhalation and use. So let's see how the colistin acts on the gram-negative bacterial cell wall. So colistin being a positively charged particle acts on the negatively charged gram-negative bacterial cell wall. So what it does, it displaces the divalent cations of calcium and magnesium, thus disrupting the 3-dimensional lipopolysaccharide structure. Then with the help of its hydrophobic end, it penetrates inside the cell, and thus the cell loses its stability, integrity, and fails to maintain the cellular contents. So overall, this causes a bactericidal effect. So as we know, colistin, being a large molecule, diffuses very poorly into the agar plates. So disk diffusion and Rayden diffusion, which is most commonly used by many labs, produce high error rates compared to the MIC based methods. So UCAST and CLSI have recommended broth microdilution as the gold standard technique for colistin susceptibility. So this study was done to compare the minimum inhibitory concentration of colistin by the gold standard technique with the automated system Vitek 2 Compact. So this is a prospective and cross-sectional study. A total of 166 non-repetitive isolates were collected, and the study was carried for about 1 year. So the isolates which were resistant to carbapenem by disc diffusion method as per CLSI guidelines were selected for the study. And the automation was carried out by Vitek 2C. So here I performed the broth microdilution. This test is mainly based on the rehydration of the antibiotics into the colistin wells with the help of Muller-Hinton broth and the bacterial suspension. And it is interpreted as intermediate and resistant according to the CLSI guidelines. So here comes our result. So out of the 166 isolates, 88% of the isolates by broth microdilution were sensitive to colistin, whereas 85% of the isolates by Vitek 2C were sensitive to colistin. And colistin resistant was 12% by broth microdilution and 15% by the Vitek 2C method. So this is the picture which shows the, this is the colistin plate, and this C denotes the control, and it is labeled as 1, 2, 3. And these are the MIC values starting from 0.25, 0.5, 1, 2, 4, 8 and 16. So first table shows the source of the infection for the carbapenem resistant Klebsiella pneumoniae isolates. Here we can see urine forms the bulk of the sample, comprising about 52%, followed by blood, pus, body fluids, ET secretion and bile. This table 2 shows the overall Klebsiella pneumoniae isolates, the intermediate and resistant cases by both the methods. Here we can see by broth microdilution, 19 isolates were resistant to colistin, whereas by Vitek 2C, 21 isolates were resistant to colistin. This table shows the serial MIC values by both the methods starting from 0.5. And here we can see again, this 5 isolates by broth microdilution have shown MIC value 4, whereas 6 isolates by Vitek 2C have shown the MIC value 4. Whereas 9 isolates by broth microdilution have shown MIC more than 16, and 10 isolates by Vitek 2C have shown MIC more than 16. So here we can see a discrepancy between the two methods when we reach to higher MICs. This table shows the overall ward distribution, and here we can see ICU, in ICU the most number of resistant cases. Statistical analysis was done here, and the p-value is less than 0.05. Moving to the discussion, so in our study we have seen that urine forms the bulk of the sample, and we found 12% of the isolates were resistant to colistin. Similar study was done by Taneja, and they found 16% of the isolates were resistant to colistin. We have also seen discrepancies in our result when compared with the Vitek. So take-home message is, in case of, we found discrepancies in our results. So in case of any discrepancies by any commercial method or by any automation like Vitek 2C, it must be correlated with broth microdilution for correlation and to reject the results. These are my references. Thank you.
Nice presentation. I would just like to know, you have done the study for MIC on Klebsiella pneumoniae. So have you compared with any other organisms, and what is the result which is preferable, or what you would like to give a suggestion about that?
Ma'am, actually I did for carbapenem resistant Enterobacteriaceae and also carbapenem resistant Acinetobacter baumannii. And the most of the resistant cases I have seen with Klebsiella pneumoniae at higher MICs. But I didn't found any resistant cases in E. coli or Acinetobacter baumannii.
Thank you, Dr. Shalini, for the excellent presentation. So I would like to start one microbiology lab, and I would like to set up the assays for this carbapenem resistant K pneumoniae. So which method you will advise me to set up?
Okay.
Which of the two methods?
I didn't understand the question.
I want to start a new laboratory, microbiology lab, and I want to set up these assays. So which method you will advise?
Sir, for new lab, I'll advise to perform this diffusion since it is easier. For broth microdilution.
Why? Based
sir,
on a sample size of 150.
to see the
Would you like
EST
to generalize that statement?
Sir, to check the resistant pattern, and this diffusion is the thing which we do for EST, but for broth microdilution, it is costly. So for setup, it's not possible.
Okay, thank you, thank you. Any question from the participants? Yes. Please use the microphone and identify yourself.
Good morning, I am Dr. Oswal from Aurangabad. I just want to ask, did you find any of the isolates?
I can't hear you, sir.
Hello?
Yes.
Yeah. I just want to know whether you found any of the isolates which were sensitive for colistin in Vitek, say MIC is less than 0.5 or up to 2, which were resistant in BMD?
Resistant cases were, as per CLSI guidelines, it's more than equal to 4. And for intermediate, they doesn't give any sensitive values for colistin MIC. They only give intermediate and resistant.
Resistant, yes.
And the MIC is more than 4, it's resistant, and less than equal to 4, it's sensitive.
No. Is there any discrepancy in results when you compare Vitek MICs with BMD?
Yes.
When the isolate is colistin sensitive?
Yeah, I found discrepancies in my study only in regarding the Klebsiella pneumonia isolates. So when we reach the higher MICs, we have found discrepancies by both the method. So we recommend broth microdilution to...
In lower MICs, I'm asking. In lower MICs?
Yeah, known MIC we have seen, because we were running the ATCC E. coli also. So we have seen discrepancies with the Vitek.
How much it was in percentage?
I think we can continue this discussion over tea, because we have got one more speaker and we are already 1 minute late.
Thank you.
So thank you very much.
Thank you, sir.
Please collect your certificate.
On Dr. Lakshmi Deshpande to give her presentation. Start, please.
Good morning, everybody. Today, I will be presenting oral paper on cord blood procalcitonin as a predictor for early onset neonatal sepsis. Neonatal sepsis is the third most common cause of neonatal mortality as per WHO. Neonatal sepsis refers to the bloodstream infection in newborns of less than 28 days of age, and when it sets in within the first 3 days, it is called as early onset neonatal sepsis, and the maternal and the birth environment are the most common causative factors, whereas when it sets in more than 3 days after birth, it is called as late onset sepsis, and the environmental factors are considered as the causative factor. The incidence of sepsis has, however, reduced over the past few years, but still it remains a matter of major concern. Worldwide, about 1.3 million cases of neonatal sepsis are reported every year, of which about 2 lakh succumb to it. In India, around 23.4% of neonatal deaths are reported due to sepsis. The signs and symptoms of sepsis are non-specific, and usually the neonates come with decreased feeding, lethargy, drowsiness, hypothermia, or jaundice, etc., which may mimic some other clinical conditions. If sepsis is not suspected and evaluated for in time, it can cause prolonged hospitalization, unwanted antibiotic treatment, and if not rightly diagnosed, can cause death. It not only causes emotional and physical burden to every family member, but also causes financial burden for the prolonged NICU admission. This can be reduced by prompt diagnosis of sepsis. Now, rationale behind the study: blood culture is considered as the gold standard for diagnosis of sepsis. However, we all know about the drawbacks of blood culture. It takes around 24 to 72 hours for culture reports, and we need good volume of blood. For neonates, we need at least 3 to 5 ml for appropriate culture reports, and also it comes with low sensitivity. Also, we need a trained person to draw blood culture from a neonate, as it is difficult to draw blood. And also, if not done properly, you'll have to prick multiple times, which will cause pain to the neonate. Also, as I told you, if the collection techniques are not proper, you might get a false positive report, and if the neonate has intermittent bacteremia, you may get a false negative report as well. Umbilical cord. Umbilical cord is neonatal blood and can be collected immediately after birth without any pain to the neonate and in good volume. Procalcitonin is a newly established marker for sepsis, routinely used nowadays for diagnosis and monitoring of sepsis treatment response in adults. Therefore, present study was attempted to study the role of procalcitonin in detection of eons in neonates. Aim of the present study is to know if single umbilical cord blood procalcitonin concentration can be used as a predictor for eons. And the objectives are to establish concentration of PCT in umbilical cord blood in newborn having risk factors for eon, compare PCT with results of blood culture in neonates having eons, and to assess the role of PCT as predictor for eons. The study of such kind has not been done in Maharashtra, and this is one of a kind in this place. If infants after birth, the PCT in infants, the PCT after birth has a physiological rise in the first 24 hours and then starts falling and reaches normal level within 24 to 48 hours. However, this is not faced when it is umbilical cord blood we are using. Materials and method. Present study was conducted between 2018 and 19 after getting ethical clearance. 129 randomly selected women with risk factor for eons were included in the present study after their consent was acquired. Those not willing to participate and immunocompromised were excluded from the study. The risk factors for eons were premature rupture for membrane, foul-smelling liquor, maternal fever, prolonged labor, or meconium-stained liquor. Cord blood was collected under appropriate aseptic conditions and was subjected to standard culture and PCT serum tests by ELISA. The neonates were followed up for 72 hours for development of signs and symptoms of sepsis, and those that did show were followed up for up to 72 hours. The other lab reports were followed up. Depending on the lab report and the culture findings, they were classified into confirmed sepsis, probable sepsis, clinical suspicion of sepsis, and non-infected, depending on the laboratory and culture findings. From the chart, we can see that the number of male and female neonates was almost similar, and the number of multipara and the number of multipara and primipara were almost similar. However, few were from LSCS section delivery as well. We can see the various distribution of risk factors of neonates born to mothers with risk factor. 3 were of confirmed sepsis, 24 were probable sepsis, and 7 had clinical suspicion of sepsis. These were the different laboratory parameters that were used to classify them depending on, into confirmed, probable, and clinical suspicion of sepsis. 3 neonates had a peripheral venous blood culture positive, and from this chart we can see that 3 of them had a peripheral venous blood culture positive, and 5 neonates were peripheral cord blood culture positive, which was not picked up by the peripheral venous blood. So cord blood culture was little better compared to the peripheral venous blood. Now this cord blood mean concentration was compared with umbilical cord blood culture, and the mean of 5.62 was considered as the cutoff. We can see that it picked up 9 neonates which were not picked up by cord blood culture. Then the ROC was plotted, and we took a 1.52 nanogram as the cutoff. With this, we were able to pick up 20 neonates which were not picked up by culture. These are the other studies that I have come across over the recent years. We can see that there are studies which took a lower cutoff, and it was observed lower than that seen in the present study. There are few studies like Kodak et al. They showed 1.2 nanogram as the cutoff, and it is similar to that observed in the present study. Not many have mentioned about the mean concentration. So to conclude,
cord blood PCT has been found to be a valuable biomarker for eons, good alternative to peripheral venous blood of the neonates. Umbilical cord blood represents simple and inexpensive method. Neonates born to mothers with eons, cord blood can be collected and preserved and can be tested later if there is any economical crisis, and those that develop signs and symptoms of sepsis, it can be gone back to and tested again. The mean PCT was 5.62 and the cutoff was 1.52. So the PCT testing of all neonates with maternal risk factor is not affordable. Then as I suggested, stored cord blood can be subjected to testing. These are my references.
So already we are ahead of time. I will just ask one question. You are suggesting that cord blood is giving better results.
Yes,
one more thing, did you have any finding regarding any change of identification in LSCS cases and normal delivery cases? Was there any difference?
Not much, ma'am. It was not statistically significant. That's why I have not mentioned it.
Okay. It is open for discussion, please.
He's passing on the mic.
Did you feel the need of having a control group like healthy
Yes,
babies?
ma'am. I have done a control also. It is previously published.
But it's not part of this study.
No, ma'am. I have previously published it and it's already in the published literature.
Okay.
So I found that in normal neonates, the mean was 2.09 nanograms per ml.
So how does it compare with the test group?
This I did only for normal neonates, ma'am.
Can PCT will be, there will be false rise in PCT in early neonatal period?
Yes.
7 to 10 days.
Ma'am, but we are using a cord blood. So this rise will not be there at all. The cord blood is taken right at birth.
Okay.
And the physiological rise will happen after birth. So we are totally avoiding the problem of physiological rise. And this is specifically for early onset neonatal sepsis.
Thank you, Dr. Lakshmi. So in the interest of the time, we will not have any more questions. So I will request Madam to kindly present certificate to Dr. Lakshmi. I would like to thank all the presenters for the excellent presentations, and it was really good to see the quality of work being carried out. Although there must be many more entries for this award, so they also must have been very good papers. So it is really going to be a tough call for the judges to decide on the winner. Over to you, Madam.
Thank you. Thank you, Dr. Anvikar. Thank you, Dr. Shilpa Shah and Dr. Anup Anvikar, to conduct the session smoothly. I request Dr. Madhuri to felicitate Dr. Shilpa Shah. Dr. Sweetie to felicitate Dr. Anup Anvikar. we will be starting the next session immediately after the first one, and that is Presidential Oration. For the oration, I welcome President IMM Chapter Conference, Dr. Neena Nagdeo on the dais, Associate Professor, Department of Microbiology, BJGMC, to introduce Dr. Neena Nagdeo.
Good morning. I am delighted to give the introduction of our President, Dr. Neena Nagdeo, Madam. Dr. Neena Nagdeo, Madam has done her MBBS and MD from Government Medical College, Nagpur. She had a huge experience of 30 years. She has a huge experience of 30 years in microbiology. She is currently working as professor and head in Department of Microbiology, NKP Salve Institute of Medical Sciences and Lata Mangeshkar Hospital in Nagpur. She had many publications in international and national journals in her credit, and she was a past president of Vidarbha Association of Medical Microbiologists, and currently she is a president of Indian Association of Microbiologists Maharashtra chapter. And today she will be delivering presidential oration. Madam, I hand over mic to you for your presidential oration.
Respected dignitaries, seniors, colleagues, and my dear friends. A very good morning from a clinical microbiologist. My talk is mostly dedicated to young microbiologists and residents who are sitting here, who are stepping on the role of clinical microbiologist. And I think for stepping into the role of clinical microbiologist, you will have to develop a smart friendship with clinicians. Microbiologists have a major role in diagnosing infectious diseases. They have to work as biomedical scientists in hospitals and laboratories, testing samples of body tissue, blood, and fluids to diagnose various infections, monitor treatment, and track disease outbreaks. Some microbiologists work as clinical scientists in hospitals, universities, and medical labs, where they carry out research and give scientific advice to medical staff. Other microbiologists work on disease-causing microbes like flu and tuberculosis, and the information they find is used to develop vaccines and improve current treatments. When we enter the field of microbiologist, we should be clear about our goal. We as a microbiologist know the importance of our work. But at the same time, do the clinicians have faith in us? Our work is not restricted to labs, but it's our duty to have interaction with treating physicians by visiting wards or critical units and communicating our findings to them. Why do we want to have the friendship with clinicians? Interruption. This is the first step when we want to have the friendship. We should be cool, patient. So why do we want to have the friendship with clinicians? Most of us think that clinicians are superior to microbiologists, and due to this belief, the clinicians try to dominate on us. It is a well-known fact that clinicians are dependent on microbiology reports. Hence, we should have a smart friendship with clinicians so that they believe on our reports. What is this smart friendship? Smart is specific, meaningful, achievable, relevant, and timely. Specific should be for the purpose and not just a time pass of friendship. Meaningful so that patients are benefited. It should be achievable. It should be relevant to the circumstances, and a timely friendship will definitely help. So, for developing friendship and better patient care, our ultimate goal is to influence clinicians and win their confidence. To achieve this goal, as a young microbiologist, you should be aware of certain things. First and most important thing is 5 roles of a microbiologist. First role is of a clinical microbiologist. Second is he should be a leader. Third role is as a communicator. Fourth role of a microbiologist is a lifelong learner. And fifth role is a professional. So, who is the clinical microbiologist? Clinical microbiologist is a person who understands and provides diagnostic services. Leader has got the capabilities to collect and analyze the situation. Communicator, because we have to communicate with patients, families, colleagues, and community. The clinical microbiologist should be a lifelong learner, and for that he has to improve the knowledge and skills. He is a professional who is committed to excellence, is ethical, responsive, and accountable to patients and community. So these are the 5 roles of a clinical microbiologist, which all of us now know these 4 roles. Now, in competency-based medical education, every microbiologist should have certain defined competencies to label him or her as a clinical microbiologist. So let us see what are the 4 important competencies which are required by a microbiologist. First and most important competency is a basic knowledge. Second is a technical skill. Third is a clinical reasoning. And fourth is communication. If I had 6 hours to chop down a tree, I would spend the first 4 hours sharpening the axe. It's a famous dialogue by Lincoln, and it's very important. We should have the basic knowledge first. As a clinical microbiologist, it is expected that we have requisite knowledge of our subject. We should constantly strive to update ourselves. Knowledge is gained not only by reading books, but by attending such conferences, workshops, and CMEs. Every opportunity to gain knowledge should be grabbed by a young microbiologist. Then comes second most important competency is technical skill. Acquisition of skill is important to boost our confidence, be it holding a loop for inoculation or molecular testing or genomic sequencing. As we cannot go away with our basic or conventional methods, our basic skills are very important. Third competency which is required is clinical reasoning. As all of you know, this clinical reasoning is required when we work for antimicrobial stewardship, when we work in hospital-acquired infections, for controlling hospital-acquired infections, and while interpreting our culture reports, we required the clinical reasoning. Then fourth competency which is required is communication. As I have said, one of the role is as a communicator. So for that, we require communication as a skill. You spend years of learning how to read, write, and speak, but we should be also learning about listening. Listening skills are also important in communication. And about this communication, it should not be just communication, it should be an effective communication. Otherwise, there will be a gap in understanding and which may lead to failure. So it should be an effective communication. So we know 5 roles of microbiologist, 4 competencies which are necessary for the microbiologist. Now we want to win the confidence of the clinicians. So I will tell you 3 steps how to win the confidence of the clinicians. First and most important step is to make other person feel important and do it sincerely. Other person is here, the clinician. So give respect, due respect to the clinician and recognitions to the clinicians. Second step to win confidence is ask for feedback from the clinician. A timely feedback from clinician will make a lot of difference in your career. Feedback may be regarding delay in reporting, maybe regarding your communication, or it may be regarding the interpretation of report. Any feedback from a clinician is always valuable. Third step to win confidence is be quick to acknowledge your own mistakes and avoid arguments. This is the problem with us. We do not acknowledge our mistakes. We will make mistakes, but learn from this. Everybody makes mistakes, but try to learn from it and accept the responsibility. The answer to the question, how to win confidence, is not a simple one. It may take months of hard work and patience before the results start to show. The key is to find your unique voice and use it to create a unique image for yourself. So these were the 3 steps to win the confidence of a clinician. Now we want to influence the clinician. So 2 ways to influence clinician. Influence is the ability to personally affect the actions, decisions, opinions, or thinking of others. Ultimately, influence allows you to get things done and achieve desired outcomes. So what are the 2 best ways to influence clinicians? First and most important as a microbiologist is the quality. So apply the Kaizen principle. Kaizen principle is continuous improvement. Strive for continuous improvement by participating in quality assessment programs. As a resident and young microbiologist working in the departments, you know about external and internal quality programs. But you should be aware about what is practiced in your lab. How do you check quality of media? How do you check antibiotic disk? And many other processes and procedures. For private labs, NABL accreditation is compulsory for certain tests. This helps in maintaining the quality, but this accreditation is not mandatory for government labs. For those working in government labs or hospitals, they need to know more about quality work. This is one way. By improving the quality, we can influence the clinician. Second way is by having a healthy relationship. Healthy relationship allows you to get things done and achieve the desired outcomes. So what type of relationship we want? Do we want this type of relationship? It's a forceful and dominating relationship for both. With this kind of relationship, we will not be able to achieve our goal. Our goal is to influence the clinician. And if we have this type of relationship with clinician, we will not influence them. So what type of relation? It should be like this. It should be harmonious, a good relationship, lovely relationship with the clinician for the benefit of the patients. It may sometimes benefit young microbiologists also. With your knowledge of about 5 roles, 4 competencies, 3 steps to win confidence, and 2 ways to influence clinicians, what is the one and only one thing that remains to achieve goal is yourself. You are the one. One and only one. So you are the one. Love yourself as a microbiologist. Be proud to introduce yourself as a microbiologist. The only belief that matters is self-belief. Believe in yourself. Unless you have faith in yourself, nobody is going to believe in you. You should build your own image like this. And you have to move out of your comfort zone. Be receptive. Change your attitude. Move out of the labs. Visit the departments, wards, and critical units and have interaction with clinicians. These changes in you will definitely influence your clinician friend, and it will be easy to win the confidence and influence him or her. Your attitude, not your aptitude, will determine your altitude. Remember, You are not a product of your circumstances, but you are a product of your decisions. I know you have entered this field of microbiology because you are interested in healthcare and keeping people healthy, because you are fascinated by all kind of germs and their DNA and RNA, because you prefer touching test tubes rather than patients, because you like to perform a variety of tasks, because you like to watch things grow, because you want to see results soon compared to several weeks or months, and because you love to solve the mysteries. Let us see how this helps. You are interested in healthcare and keeping people healthy. That is why you are developing vaccines. You are fascinated by all kinds of germs and their DNA and RNA. That is why you are performing RT-PCR test. You prefer test tubes versus patients. That is why you prefer lab work. You like to perform variety of works like working with HICC, antimicrobial stewardship, and research. You like to watch things grow. That is why you grow beautiful, colorful microbes in your lab, bacteria in your lab. You want to see results soon. That is why you are interested in automation. You love to solve mysteries by working for the outbreaks of infectious diseases. So friendship with clinicians will differ in different setups, whether it is government or private setup. I have no experience with government setup because I am working with private hospital since 30 years. But I know there is some problem with having a friendship with clinicians, but at private hospitals, clinicians are somewhat receptive. They like to have a word with microbiology, so it's easy to develop friendship with them. Try to conduct CMEs in association with the clinicians. Educate regarding basic requirement, like how to fill a requisition form, which is very important for giving a correct report. Also for antibiotic stewardship, do CMEs with them. A word of caution for all the microbiologists who are present here. Never talk about the role of microbiologists in clinicians forum, but tell them what is expected from them for better reports. Ultimately, it is a teamwork, open-mindedness, and the adventure of finding new solutions to the old problems. But it doesn't happen on its own. It's a process, and through that process, people bring all their personal experience and expertise to the table. Together, they can produce far better results than they could individually. This smart friendship will create a win-win situation, which will be helpful for better patient care, leading to better doctor-patient relationship. So let us take efforts to bridge the gap between clinician and microbiologist and be smart friends with clinicians. Lastly, I appreciate your patient listening to a sensitive topic. I specifically thank the organizers for inviting me to deliver presidential oration in front of colorful colonies of microbiologists. Hope that all of you will start developing a policy to change your phenotype so that a cultured microbiologist will achieve its goal. You start developing a symbiotic relationship with clinicians, but at times be an opportunist to show your importance to the community and to the clinicians. Remember, coming together is a progress, is a beginning. Keeping together is a progress, and working together is success. So, a thank you from the orange city of Nagpur, which is also a tiger city. Thank you all.
Thank you, madam, for an excellent and useful presentation, and with few points to ponder, like feedback from clinicians and interpretation of reports. I hope the smart friendship of microbiologists and clinicians will flourish over the period and lead to an extremely fruitful association. And yes, communication is the key to the same. I request Dr. Karyakarte, Organizing Secretary, and Dr. Smita Deshpande, Joint Organizing Secretary, to come on the dais to present a scroll of honor to Dr. Neena Nagdeo. Before presenting, I request Dr. Rajesh Karyakarte to read the scroll of honor.
This is the scroll of honor which we are honoring her with, and we would be very thankful if she accepts this one. But before that, I would like to read something from it. So please, yeah. Dr. Neena Nagdeo, she is the Professor and Head Department of Microbiology, NKP, MS, and RC, and LMH. I hope you understand what I taught. Nagpur, Maharashtra. Dr. Neena Nagdeo, President, Maharashtra Chapter of Indian Association of Medical Microbiologists for the year 2018 to 2019. But COVID has made something very peculiar because the new president hasn't taken over and the old president hasn't given over the charge. So she is the only one who is the president from 2018 to till today for 3 years. So that's quite an honor for you. Yeah. She presented her oration right now, Clinicians, Smart Friendship, on the occasion of MahaMicroCon-2022, the 26th Maharashtra Chapter Conference of Indian Association of Medical Microbiologists at BJ Government Medical College, Pune. It's my honor to hand over the oration to her. Please, madam.